Welcome back to Part 9 of our Evaluation and Management Explainer series. If you're a CPC, an auditor, a biller, or a CDI specialist, you're in exactly the right place. So let's just dive right into this. Today, we're demystifying Chart C by mastering the vital nuances of minimal to moderate risk in medical decision-making.
Let me kick things off with a quick question for you. Does a mere 1% chance of mortality mean a patient is at a low or high risk? Seriously, think about that for a second. It's kind of a trick question, and it frequently trips up even seasoned coders because, well, we often confuse mathematical probability with clinical severity. We're going to solve that exact puzzle right now. Here's our agenda for today. First, foundations of MDM risk. Second, minimal risk interventions. Third, low-risk interventions. Fourth, moderate risk interventions. Fifth, a spotlight on social determinants. And finally, takeaways and a Part 10 teaser.
Section 1. Foundations of MDM risk. So, according to our coding guidelines, risk actually refers to the chance and the possible impact of a medical treatment, test, or decision. It considers both how likely something is to happen and how severe the outcome would be if it literally did happen. Remember that question I asked a minute ago? Well, a 1% chance of death still counts as high risk. Why? Because even though the probability is incredibly low, the outcome, mortality, is literally as severe as it gets. On the flip side, a really high chance of a mild side effect might just be low risk, simply because the outcome isn't dangerous.
Now, the crucial point here is that morbidity is all about lasting impairment and functional limitation, right? It's not just a temporary symptom. We're looking at states of illness where a patient's quality of life is impaired, or where there's a real risk of organ damage that might not just go away, despite the treatment provided.
Which brings us to an absolutely fundamental rule of medical auditing. Providers assess risk based on their training and their clinical judgment, not exact numbers. Risk is deeply rooted in the specific problems being treated and the actual real-time decisions the provider makes during that visit, like choosing to perform or even choosing to delay further testing. It's a clinical judgment call through and through, not some arbitrary math score.
Section 2. Climbing the ladder. Minimal risk interventions.
All right, let's look at minimal risk. At this absolute baseline tier, the condition and the management plan have a very, very low chance of causing any harm or complications. These interventions are incredibly safe, extremely basic, and mostly revolve around simple self-care routines.
Let's break down some of these chart-ready clinical examples. We're talking about telling a patient to get some rest for a viral illness, or recommending saltwater gargles for a sore throat, maybe applying an elastic bandage for a minor sprain, or using superficial dressings for simple cuts and abrasions. Now, as coders, you'll immediately notice that absolutely none of these involve invasive interventions or deep wound care. They are the textbook definition of minimal.
Section 3. Climbing the ladder. Low-risk interventions.
Moving up the ladder, low-risk interventions have a low but very much present risk of causing harm. They're still generally safe interventions for the patient, sure, but they require a slightly higher level of medical consideration and expertise than that minimal tier we just covered.
Let's look at these specific examples carefully because, the nuances really matter here. Recommending an over-the-counter drug, like paracetamol or an antacid, is low risk. Minor surgery without identified risk factors, think a simple skin tag removal, also falls right in here. So does physical or occupational therapy and giving IV fluids without additives, like normal saline. But hey, pay super close attention to this last one, prescription refills without documentation of active management. Renewing a medication without actively reassessing the patient's current condition, that keeps you squarely in the low-risk category.
Section 4. Climbing the ladder. Moderate risk interventions.
Okay, so moderate risk involves management where the patient or the treatment has some clear risk factors that could cause complications. The risks are manageable, yeah, but they absolutely require active clinician oversight and monitoring. It's a real step up.
Now let's walk through these examples because this is where the coding action really gets going. The most common trigger for moderate risk is prescription drug management. Now, this means actively starting, discontinuing, or adjusting a medication that requires ongoing monitoring, like an antihypertensive or an oral hypoglycemic. We also see decisions for minor surgery with identified patient risk factors, and decisions for elective major surgery without identified risk factors. For example, planning a routine knee replacement in a totally healthy patient.
So the exact boundary line often just comes down to clinical context. If a doctor performs a minor surgery without risk factors, it's low risk.
But if that exact same minor surgery is performed on a patient with a comorbidity, say a minor excision on someone who is anticoagulated or diabetic, that patient risk factor instantly bumps the whole intervention up to moderate risk. The clinical context changes the whole shebang.
Section 5. Spotlight. Social determinants of health.
Social determinants of health, or SDOH. When economic, environmental, or social conditions significantly limit a patient's ability to be diagnosed or to follow a treatment plan, the inherent clinical risk automatically increases. I mean, think about it realistically. If a patient literally cannot afford their prescribed medication, or they lack transportation to even get to a pharmacy, the medical plan is at a much higher risk of failure.
CDI specialists and coders, I want you to mentally bookmark this exact SDOH ICD-10 Spotlight Matrix. These specific Z-codes definitively support moderate MDM risk when they're properly documented by the provider as impacting the care plan. We're looking at codes for illiteracy, homelessness, lack of adequate food, extreme poverty, and even problems related to living alone or release from prison. If the provider documents that these factors complicate the management plan, well, you've got a rock-solid foundation for moderate risk.
Section 6. Takeaways and Part 10 Teaser.
Okay, to quickly summarize our Element 3 journey today. First, always differentiate the foundational definitions of risk versus morbidity. Just remember that high-severity outcomes mean high risk, completely regardless of probability. Second, make sure to map your clinical intervention strictly to the minimal, low, or moderate tiers based on active management versus passive recommendations. And third, always recognize that social determinants of health profoundly impact patient outcomes and elevate that management right up to moderate risk. Precise clinical context and social determinants really are everything in accurate coding.
And that brings us to the top of our ladder for today's explainer. But we definitely aren't done with Chart C just yet. Coming up in Part 10, we're diving into MDM Element 3, navigating high-risk and high-stakes clinical management. We're going to be exploring intense, high-stakes decisions, like drug therapy requiring intensive monitoring for toxicity and emergency major surgery. You absolutely won't want to miss that final critical tier of Chart C.
Before you audit your next file, ask yourself, what moderate risks or social determinants might be hiding in plain sight in your patient's chart? Keep your documentation precise, keep learning, and as always, decode healthcare with Harshal.